end of the session.
Yes, it's a great pleasure to present the next speaker about PSMA-PET CT imaging pitfalls. Very interesting, and the speaker is Yehia Omar from Egypt.
Thank you. Thank you for the introduction. Good morning. It's my pleasure to be with you today in the International Congress of Radiology. I'm going to present PSMA-PET CT imaging pitfalls. It will be more case-based oriented. I hope we can have some interaction together. So I will start straight away with a real case scenario. So let's assume that we have a patient referred to our department. He has a newly diagnosed cancer prostate, and now the aim of our study is to know whether the patient has localized cancer prostate or has metastasis to lymph nodes or bones. So this is the main indication of the study now. So now we can see the primary prostate in the red arrow. Now let's assume in the abdomen we have this. We have two rounded active nodules in the para-aortic regions. So what are they? Now you have two options to report that, and two pathways that are completely different than each other. The first one is to report these as normal uptake, so the patient will be candidate for local treatment, whether surgery or radiotherapy, or the other pathway, that these are metastatic abdominal lymph nodes, then the patient will receive systemic treatment and he will miss the opportunity of having a local therapy. So completely different pathways according on how we report our case. This is why identifying pitfalls is crucial to avoid false reporting, which leads to choosing the wrong therapeutic plan. Now let's get back to our case. It was image A. Now we added two more images. We have image A, B, and C. Only one of them has a metastatic lymph node. Do you know which one? Exactly. C is the metastatic para-aortic abdominal lymph node. And A and B are called celiac sympathetic ganglia. And this is completely normal uptake. We can see this is the first one. This is the right celiac ganglion, as you can see it here. This is the left-sided celiac ganglion. Again, this is completely normal. Also, we can see cervical ganglia, as the one seen here. And we can see also sacral ganglia. So the teaching points in the first case, that active ganglia can be seen in up to 90% of the patients. They can be seen in cervical region, celiac region, and sacral locations. And it is very, very important not to be confused with metastatic lymph nodes. Now let's move to the second case. So this is an 81 years old male patient with newly diagnosed high-risk prostate cancer. So this is the bone scan. Now we can see increased tracer uptake occupying most of the pelvis, the right femur, as well as left humeral head. So they thought that was metastasis or not, so they performed PSMA-PET CT for this patient. And here is the PSMA-PET. We can see increased uptake in the same regions as in the bone scan. So again, are these metastases or not? And this is the CT appearance of the pelvic bones. Again, our question, metastasis or not? This is another case showing the same pattern. We can see the right iliac bone. There is increased PSMA uptake. So this is metastasis again or not? Does anybody know what that is? Exactly. This is Paget disease. Exactly. So the teaching points here that Paget disease is a chronic metabolic bone disorder that can be found in up to 5% of the population. It is characterized by bony expansion, thick cortex, and bony trabeculation. And it's important not to confuse that with metastatic bony deposits. Now let's move to another case. Do you know what that is? Exactly. This is normal parotid glands. This is completely normal in PSMA uptake. Now my question is, what is that? Exactly, this is accessory parotid gland. And it's important to know that accessory parotid glands can be seen in up to 20% of the population. They are seen anterior to the main parotid gland, and it's important not to confuse that with metastatic lymph node or metastatic lesion. Now let's get back to the PSMA-PET tracers. Like Dr. Patrick said, we have different types of PSMA-PET tracers. We have different gallium PSMA tracers and different fluorinated PSMA-PET tracers. In Egypt, we only have two types. We have gallium PSMA-11 and fluorinated PSMA-1007. And this is how they look. Which is gallium and which is fluorine? Gallium is A or B? Does anybody know? Exactly. Gallium is A because gallium, the main difference between gallium and fluorine is that gallium is urinary excreted. So you will see uptake in the bladder. Fluorine PSMA-1007 is hepatobiliary excreted. So you will see increased uptake in the liver, and you can see the gallbladder also. And you will not see any uptake in the bladder. And this is very helpful when we are looking on the post-prostatectomy operative bed. We don't have any urinary uptake, so fluorine PSMA is preferred in this scenario. Now let's move to the disadvantages of fluorine PSMA-1007. So this is another case, post-prostatectomy patient with recent re-elevation of PSA level reaching 0.2 nanogram per ml. So now the patient is referred to us to identify where is the site of recurrence. We can see a very tiny focal lesion in the operative bed, and that it's local recurrence. We can see it very clearly now. Now the main controversy and the main question, what do we have in the ribs? We can see tiny hot spots in bilateral ribs as seen here. And these are the fused images of the PET. We can see active foci here and here. And in the CT, there is no correlation to support are these metastatic lesions or not. So now my question is, does the patient have local recurrence and metastatic lesions in the ribs, or only local recurrence? Again, very different pathways and big difference. The answer, no, they are not metastasis. And this is a common pitfall, especially when using the fluorine PSMA-1007, and these are called non-specific bony uptake. And these lesions were identified in up to 51% of the patients using fluorinated PSMA-1007, and they are characterized by having focal mild to moderate uptake, usually with SUV max less than 10. And what's important on the CT part, we do not have any morphologic appearance to know whether they are definitely benign or definitely malignant. We don't know. We only see focal spot and we cannot characterize it. And the most common location to see that are in the ribs, as in this figure. They are almost 57.5% seen in the ribs, then followed by the pelvis. So when you are reporting a case with PSMA-1007, please report with caution, because if you're going to upstage the patient and call him as a metastatic while he's not metastatic. So it's a very important difference. Also, another teaching point, very important, regarding the prostate bone metastasis distribution is that prostate cancer bone metastases tend to start in the spine and pelvic bones. And usually they start from inferior to upwards because they spread through the venous plexus from the prostate to the vertebrae. So they usually start in the spine from the lumbar or sacrum, then spreads gradually upwards. So we don't usually see isolated rib metastasis. This is very rare because usually bones spread to pelvic bones, then spine, then everywhere else. So if you have isolated rib metastasis without bony lesions on other sites, then please think twice because usually these will not be metastasis. Now let's move to another case. So this patient has a single active left occipital brain lesion without other lesions in the body. So the question again, metastasis or not? No other lesions in the body. Metastasis or not? And these are the MRI images of it. What do we see now? Homogeneously enhancing dural based lesion, and this is, yes, exactly, meningioma. Also another case, again, a single active hepatic focal lesion without other lesions in the body. This is the key word, that there are no other lesions in the body and only a single hepatic focal lesion. This is not metastasis. Actually, this was hemangioma. If the patient was cirrhotic, it can be HCC, because also HCC shows high PSMA uptake. So the teaching points of the last two cases, that we need to understand the typical pattern of metastasis of prostate. Prostate spreads first to bones or lymph nodes, then to visceral deposits. So if you see something abnormal, think twice. If you see unusual pattern or abnormal site of PSMA uptake, then it is more likely to be of non-prostatic origin. Now let's move to another case. So this patient has widespread metastatic lesions. As you can see, he's totally black. And unfortunately, he has multiple hypodense hepatic focal lesions that are not active on the PSMA-PET scan. So the question now, metastasis or not? Do we believe the CT, where we have hypodense hepatic focal lesions, or do we believe the PET, that they are not active, so they are not metastasis? What do you think? Another case with the same teaching point. Patient has multiple metastatic osseous deposits. However, he has multiple large inactive pulmonary nodules. So how are we going to report these pulmonary nodules? Again, metastasis or not? So the teaching point here is that these are non-PSMA avid deposits. And usually this happens in the late stage of patients after several lines of treatment. The patient becomes hormone resistant and the cancer cells lose the PSMA receptors. So they do not show uptake on the PSMA-PET. Also, if you're looking into theranostics, this patient will not be eligible for lutetium therapy because now the tumor lost the PSMA receptors, so we cannot target these lesions using lutetium 177 PSMA radioactive therapy. Also from our experience that almost 5 to 10% of newly diagnosed cancer prostate do not show PSMA expression. Dr. Patrick was saying now it's almost 20% at your site. We think it's around 5 to 10% at our facility. So it's important to know that not all prostate cancer will have PSMA uptake. Now this is my final slide. Again, Dr. Patrick said that multiple times, that size matters. And they discovered that if the tumoral deposit is around 4.5 millimeter, we have a high detection rate. We can detect that in almost 90% of the case. However, if the tumoral deposit is very small, around 2.3 millimeters, then our detection rate decreases significantly, almost to up to 50%. So it's important to know that negative PSMA-PET does not exclude micrometastasis. There will always be very small deposits that the machine cannot detect. And this is because of the physics, as we said, and due to the crystals and detectors. So my final remarks, PSMA-PET CT, I believe, is a game changer with marked impact on patient management. And good knowledge of pitfalls is crucial to avoid wrong therapeutic strategy. And finally, correlation with clinical data is essential to help interpret difficult findings. Thank you very much.
Thank you very much, Dr. Yehia, for your presentation that highlighted the pitfalls that we actually encounter in practice reporting. And now it's my pleasure to introduce